Greetings, everyone. My name is Cristiana Baloescu. I'm a faculty member in emergency medicine at Yale. And today I will be discussing the project entitled Beeline Presence and Related Diagnoses in Emergency Department Patients Presenting with Undifferentiated Dyspnea. Thoracic point-of-care ultrasound is increasingly being used by many specialties to aid in the evaluation and monitoring of patients with shortness of breath. In the emergency department, the detection of beeline artifacts using point-of-care lung ultrasound can aid in identifying causes of dyspnea. Beelines are hyperechoic ring-down artifacts that extend from the pleural line to the far field without tapering, as seen in the video on the slide. They occur when the ultrasound beam encounters a bubble tetrahedral complex, which is also represented on the slide. This is formed out of 4 air bubbles arranged in a tetrahedron formation and trapping a horn-shaped column of fluid within. Beelines denote the presence of interstitial fluid under the term alveolar interstitial syndrome and can be found in pathologies such as pulmonary edema, congestive heart failure, pneumonia, acute respiratory distress syndrome, pneumonitis from COVID-19, and other pathologies. Data on the range of diagnoses among an undifferentiated group of dyspneic patients with respect to beeline presence is scarce in the literature. We sought to describe in detail diagnoses associated with dyspneic patients with beelines on thoracic ultrasound who were evaluated in the emergency department. We prospectively enrolled consecutive adult patients presenting with dyspnea or hypoxia, triaged to high acuity areas of an urban academic emergency department. Ultrasound of 8 lung zones, right and left anterior lateral and superior inferior zones, was performed with a Philips Lumify phased array transducer. Subjects found to have beelines on initial lung ultrasound in the anterior superior zones, identified in red on the photo in the slide, were included in the analysis. Subjects were followed until hospital discharge. The EPIC chart was reviewed for discharge diagnoses. For subjects admitted to inpatient units, the primary or principal diagnosis, as well as any secondary diagnoses, were recorded from the discharge summary. And the slide contains a clip, a snapshot sort of illustrating how these diagnoses were displayed in the discharge summary. For patients or subjects discharged from the emergency department, the primary diagnosis as well as any secondary diagnoses were also recorded from that DC tab in EPIC. 184 subjects were enrolled in the study in total. Out of these, 64% or 119 subjects had beelines on screening ultrasound and were included in the analysis. 96% of the subjects were admitted to the inpatient unit, and 4% were discharged from the ED. And this 96% refers to the 119 subjects with beelines. Out of the total of 119 subjects with beelines, 59% had either a primary or secondary diagnosis of heart failure or pulmonary edema. This constituted the majority of the sample. The next largest category, or 13%, had respiratory failure or shortness of breath that was not otherwise specified did not have a specific diagnosis. 11%, interestingly, represented a category of diagnoses unrelated to any primary lung pathology. And this was a surprising finding. Examples of diagnoses expected to result in primary lung pathology and where one might expect to have changes resulting in beelines on ultrasound include bilateral pulmonary embolism, lung cancer, influenza, or interstitial lung disease. Examples of diagnoses not expected to result in primary lung pathology and found in this sample included acute kidney injury, alcohol withdrawal, acute coronary syndromes, preeclampsia, etc. There is a greater heterogeneity of diagnoses in dyspneic subjects with beelines on point-of-care ultrasound than previously thought. Results show a number of diagnoses inconsistent with known causes of alveolar interstitial syndrome. These results are hypothesis generating. Presence of beelines in subjects where such artifacts would not have been expected could mean a few different things. Firstly, it could mean the presence of undiagnosed or subclinical heart failure or pulmonary edema, or other causes of alveolar interstitial syndrome. Secondly, B-lines have been described in healthy elderly individuals, so it's possible that these B-lines are found in otherwise not pathologic conditions. Thirdly, B-lines in such patients could indicate a complication of their primary diagnoses and presence of undiagnosed disease complications. While pulmonary edema and congestive heart failure compose the preponderance of patients with dyspnea and B-lines, a wide variety of diagnoses were present. This potential for additional relationships between B-lines and other disease processes requires further investigation.